of coronary physiology measurements, either measuring FFR, IFR in the cath lab. As we all know that the major limitation of coronary angiography is that it's a two-dimensional imaging of a three-dimensional structure, which is a coronary, epicardial coronary vessels. And adding physiological assessment to the angiographic appraisal of coronary stenosis, it enhanced the accuracy of diagnosis, and it also helped to optimize the selection of the best management strategy for your patient. Let's start my presentation, for example, with this case. This patient is a 53-year-old obese patient complaining of typical angina on exertion despite medical treatment. And this is his coronary angiography, shows this mid-LAD stenosis and ostial borderline lesion of the circumflex and another plaque in the OM. So by doing IFR, for this patient, the LAD proved to be functionally significant, and the IFR for the circumflex was 0.97, which means that's not significant. So just doing the PCI to LAD improved the symptoms of the patient and avoided unnecessary intervention for this circumflex. And we know that even intervention for this circumflex may have some complications, despite that the angle is good, but it may compromise the flow of the LAD. And so you avoid an unnecessary intervention for functionally not significant stenosis in the circumflex. So functional assessment, either by IFR or FFR, can change the treatment strategy. And here, this is a large French multi-center FFR registry, showed that FFR changed the revascularization strategy in up to 43% of the patients. And similarly, we have actually published an Egyptian experience for a retrospective analysis of 156 patients. Actually, it was done in Aswan, and proved also the same, that around 39% of the lesions that angiographically seems to be significant were found to be functionally not significant by FFR. And also 33% of the lesions that seems to be functionally not significant were found to be significant by FFR and necessitated PCI. So it did change the treatment strategy for your patient. And the data on clinical outcome, as we all know from the FAME2 study, that FFR can change the need, FFR significantly decrease the need for unplanned revascularization with significant improvement and relief of angina, but there is no effect on either mortality or non-fatal myocardial infarction. So it decreases angina, it decreases the need for unplanned revascularization. However, there is no effect on mortality or MI. And the current guidelines gives a class 1 recommendation to do FFR or IFR to assess the hemodynamic relevance of intermediate stenosis. And we know from the guideline that the definition of intermediate stenosis range between 50 to 90%. So you can do an IFR or FFR for these lesions to prove that it is functionally significant. And we know that FFR guided PCI has impact on the prognosis based on the current literature. And there is a class 2A recommendation to do an FFR in patients with multi-vessel disease to guide PCI. So to do only PCI for the functionally significant vessel and defer the vessels who prove to be functionally not significant and leave them on medical treatment. But importantly, to achieve all these benefits of FFR on the clinical outcome, you should measure it accurately. And in order to obtain accurate and not false measurement, there is some issues that you should take care while measuring FFR or IFR. The first thing is calibration and equalization. What's meant by calibration? Calibration is teaching the system what's zero pressure. Firstly, you calibrate the aortic pressure to accurately measure the aortic pressure, because we know that either FFR or IFR, you are measuring the distal coronary pressure and in relation to the aortic pressure. So you should have an accurate measurement of the aortic pressure. And this is very important. The first step in the cath lab, while you are measuring FFR or IFR, you should have a look on the position and the height of the pressure transducer that measure the aortic pressure. The transducer should be at the level of the heart, the junction between the upper 1/3 and the lower 2/3. And you know the patients are different. Sometimes you have a slim patient, sometimes you have a morbidly obese patient. So definitely the position of the transducer will not suit all patients. So you should check if the transducer at the level of the heart, and this is really important not only for FFR, for any hemodynamic assessment, for example, measuring the pulmonary artery pressure and right heart catheterization. This is really very important step. And you can appreciate here that if the transducer is a little bit high, so you will have a false low aortic pressure. And if the transducer is a little bit down, so you will have a false high aortic pressure, and this will give an inaccurate FFR measurement. The second thing is equalization. What's meant by equalization? You are teaching the two systems to be synchronous. The system which measure the aortic pressure, and the system which measure the coronary pressure. And we know that the sensor that measure the pressure present between the junction between the radio-opaque part and the rest of the wire. So you place this sensor just 1 to 2 millimeter distal to the tip of the guiding catheter, and you do an equalization at this point before going down to the coronary vessel. Importantly, during equalization, you should remove the needle, because if the needle, the introductory needle actually in the Y connector, if the needle is present, so it will give a false equalization. So the needle should be removed during the equalization, and also during measurement, and also at the time of final check for the absence of drift at the end. The second thing that you should avoid the placement of other coronary guide wire. If there is other coronary guide wire present in the guiding catheter or in one of the coronary vessels, there is some mechanical interaction that can happen and also may give a false measurement. The second important trick is you should look at the pressure curves, not only the number that you found on the screen, because the pressure curves that you see either for the aortic pressure or the distal coronary pressure must be stable for several heartbeats, because FFR it measures the mean pressure, which is the average of 3 to 5 heartbeats. So the curves should be stable and similar for several consecutive beats, and it should be free of several artifacts. And I will mention now what kind of artifacts that you should be mindful. You should be aware of these artifacts while looking at the pressure curve. The first artifact, you should look at the, for example, this red curve, the aortic pressure, because it could be dampened or ventriculized due to deep engagement of the guiding catheter in the left main or in the right coronary artery. So wedging can happen either due to malalignment of the guiding catheter. So importantly, you should select a shape of the guiding catheter that should allow coaxial alignment of the guiding catheter in the left main or in the right coronary artery to avoid wedging or damping or ventriculization of the aortic pressure. The second, this also can happen due to the presence of a plaque or mild even stenosis at the ostium of the of the left main or the RCA. You can imagine here, for example, that a 6 French guiding catheter in a completely normal vessel, it can induce around 25% area stenosis in the left main or in the RCA. And if you have only 20% stenosis, for example, in the left main or the RCA, it can induce up to 39%. And this jump to 56% if you have only a 30%. This is a not significant stenosis, but the presence of guiding catheter inside this mild plaque in the left main or the RCA can induce stenosis, can impede the coronary blood flow, and can lead to damping or ventriculization of pressure. So very importantly, during the calibration, during equalization and during measurement to selectively and completely disengage the guiding catheter out of the ostium to have accurate measurement and to have this regular curve for the aortic pressure. The third point is you should avoid the use of guiding catheter with side holes. We don't use actually a guiding catheter with side hole, but it's the turbulence that can happen at the tip of the guiding catheter can impair the process of equalization and accurate measurement of FFR. And also, if you are giving, for example, adenosine intracoronary for measuring the FFR, it will the whole dose will not reach the coronary. It may escape in the aorta. The second artifact is what's called whipping artifact. What's meant by whipping? Here you are looking at the pressure, the coronary pressure curve, the distal curve. For this one, the green one. Whipping artifact means there is a significant variation in the coronary pressure. So what does it mean? It happens due to mechanical interaction of the pressure sensor with the wall. It hits the wall. It happens in small vessel, small coronary vessel, or if it's severely tortuous. So the pressure sensor can hit with the movement, the vessel wall, lead to significant variation of the pressure curve. And this actually, you know that FFR depend on an average of 5 beats, for example. So it will also give false reading. So you should, for example, actually withdraw a little bit the wire to keep it away to minimize this mechanical interaction. So here, for example, in this case, you have a pronounced whipping. There is a significant variation while it hits, it gives false high pressure. And here there is a minor whipping. So you should have a slight variation of the coronary pressure and avoid a pronounced whipping artifact. The third artifact is drifting. What's meant by drifting? You should, drifting means that the two systems forgot to be synchronous. We equalized it at the beginning, and while measuring, they forgot this process of equalization, and they are not synchronous anyway. And you check this at the end of measurement. You should, after getting your measurement and reading, you withdraw again the pressure sensor, place it again just 1 to 2 millimeter distal to the tip or at the tip of the guiding catheter to check that it's one. So they are still equal, they are still synchronous, and no drifting happen. And there is some clues actually for drifting. You can check the true gradient, means that here, this is the aortic pressure. The curve should be different. There is a different morphology and no notch, no dichrotic notch in the coronary pressure. There is a clue for drifting if you found that the two curves are similar with a dichrotic notch on the coronary or on the coronary pressure wire. So at this point, you should withdraw again, do another equalization. You should teach them again that they are equal and synchronous, and then remeasure the FFR or the IFR. The third point is, do we need to do hyperemia or not, based on the current evidence that we have? Now, we know firstly that we have the FFR and prove that it is really have an impact on the outcome. And now we have several non-hyperemic pressure ratios, not only IFR. We have actually a long list now of non-hyperemic pressure ratios. The most validated of them is IFR, based on the data from the Sweetheart and the defined flare studies that showed that it is non-inferior to FFR and by the impact on the clinical outcome and the adverse clinical events. The IFR is the instantaneous wave-free ratio, which means the difference or the difference between the distal and the aortic pressure during the wave-free period, which represents 75% of the diastole. There is no waves here, which means that the resistance is really very low and stable. And without hyperemia, measuring just the ratio is well validated now. And actually, as I showed you before in the guidelines, the IFR is written in the guidelines as an alternative to FFR for functional assessment of the coronaries. And here, this is really very nice algorithm that if you have an angiographic stenosis, that you are doubting the severity, when the range now between 50 to 90, sometimes down actually to 40%. Firstly, you check the IFR, which is without giving any adenosine or without inducing hyperemia. And the value, we know the cutoff value is 0.89, but this value, you can use it if you have the clinical symptoms or non-invasive testing consistent with ischemia. So if the patient really complaining of angina and there is an evidence of ischemia clinically or non-invasive, so once the IFR 0.89 or below, so you can go for PCI. And if it is between 0.9 and 0.93, you can, and the patient have angina, so you can consider FFR doubly checking by giving adenosine and see if the FFR 0.8 or below, so you can go, so you can proceed with PCI. If it's more than 0.93, so you can defer and keep the patient on medical treatment. But if the patient does not have really clinical symptoms of ischemia, or there is no non-invasive evidence of ischemia, the value of IFR should be 0.86. If it's below 0.86, so proceed for PCI, because really this is a functionally significant. If it's between 0.86 and 0.89, so it's better as long as the patient does not have any clinical symptoms or no non-invasive testing. You can double check and consider doing an FFR. And if the FFR 0.8 or below, so you can proceed with PCI. And how to do FFR? FFR is not inducing hyperemia. You should achieve maximal hyperemia. There is, without maximal hyperemia, there is no accurate FFR measurement, and you induce hyperemia either by intracoronary or intravenous adenosine infusion. And intravenous adenosine infusion needs a large bore cannula, or it's better actually to put a femoral vein sheath. But intracoronary, you give, the standard is to give 100 mic in the right coronary artery and 200 mic in the left coronary artery. There is some data which is not present actually in the studies of the FFR, to double the dose of adenosine if you did not achieve or there is no evidence of hyperemia. Importantly, if the patient developed EV block while giving adenosine, you should repeat. You should not depend on FFR value while the patient has EV block or significant P-wave asystole. No, you should decrease the dose of adenosine and repeat FFR measurements. Importantly, if you are giving intracoronary adenosine, you should well engage your guiding catheter to ensure that the whole dose of adenosine reaches the coronary artery, and then quickly disengage immediately at the end of injection to avoid the wedging phenomena as we highlighted before. And importantly, you should not flush with contrast. So you give, actually this really very good paper which gives some standardization of how to measure FFR. It gives really nice trick is, so for example, if you're going to inject 5 milliliter of adenosine in the left main, so inject 7 to 8 millimeters. So add 2 to 3 milliliter to occupy the dead space within the guiding catheter, and then stop and change the manifold to measure the IFR without flushing the adenosine with saline or even contrast. And this really give, you know, that the adenosine is rapidly working. So just measure the FFR by injecting additional 2 to 3 millimeter to occupy the dead space of the guiding catheter. Here, it's really very clear when you flush with a contrast and you fill the guiding catheter with a contrast, actually it gives falsely low IFR value. So when you are measuring IFR, you should flush only with saline. When you are measuring FFR and give adenosine, just add 2 to 3 milliliter from the prepared adenosine in the syringe. The presence of microvascular dysfunction, actually patients with history of previous MI, significant left ventricular hypertrophy, or diabetic microangiopathy, they may have some microvascular dysfunction, and you cannot achieve a maximal hyperemia in those patients. But really the change or their effect on this is really very small, but it could be of a clinical value in patients with borderline FFR. And we know actually that all the studies actually on FFR excluded patients with MI or LVH. So there is a certain groups of patients that were not really included or tested in the FFR studies and in the famous study. They are excluded. They excluded the left main, patients with history, definitely recent STEMI, especially the culprit vessel. Patients with LV dysfunction were excluded. So we do not have strong data to support the use of FFR. We are using actually this and extrapolating that the value, the FFR will be of similar benefit, but this group of patients were not yet studied. Also, those with significant LVH and patients with history of bypass grafting. There is other new non-hyperemic indices. Now we have, other than IFR, but not validated, or the clinical outcome or impact of using this indices on the clinical outcome has not been validated in randomized studies. We have the resting distal to aortic pressure. There is a resting whole cycle. Here, the IFR is a ratio between the distal coronary and the aorta during the wave-free period, which represents 75% of diastole. This actually measure without inducing hyperemia, just the difference between the distal and the aorta during the whole cycle, the whole cardiac cycle. And here, this is a study which really showed very good agreement of this ratio, the distal to aortic coronary pressure ratio with IFR in this study, but there is no outcome data available to support this. We have also the DPR, and now in Egypt, actually, we have a new wire, the OptWire from Opsense, which use fiber optic technology. And really, the wire itself has very good properties, and really the connectivity of the wire and the use of the wire again for PCI, it's really very good. And now it's available in Egypt, but there is no clinical outcome data on this DPR. DPR just is during diastole, so it's the ratio between the distal and aortic pressure during diastole. So we have IFR during the diastolic, during the wave-free period. We have the DPR during the whole diastole, and we have also the resting distal to pressure without ischemia, without inducing hyperemia during the whole cycle, like FFR, but without giving hyperemia or without giving adenosine, and it has a good agreement with IFR. What's the effect of right atrial pressure? Why we are asking about right atrial pressure? We know that FFR, it is a ratio between the maximal flow in the presence of stenosis relative to the resting flow. Flow mean pressure gradient divided by resistance. So it is the measured pressure, either distal or in the aorta, and actually we are subtracting coronary venous flow, which is equivalent to right atrial pressure. لأن coronary sinus بتفتح في right atrium. So the coronary sinus pressure and the right atrial pressure, but because actually the right atrial pressure in the majority of patients is really low, so it is actually neglected and omitted for simplification of measurement of the FFR. So the FFR omit the value of right atrial pressure. And this study showed the impact of right atrial pressure on FFR. And they measured the right atrial pressure and put it in the formula, put it in the calculation to see whether there is a difference or not. But really, it showed that really the difference is really very minimal, even at a mean right atrial pressure of 4, 7, or 12. So the conclusion of this study that the right atrial pressure effect is really very minimal, and is of not does not have a significant impact on the measurement of FFR. However, In this study, as we see, there is no patients with high right atrial pressure. So I think if you have patient with LV dysfunction, heart failure, and expected has neck veins, and expected that you have a right atrial pressure more than 20, for example, or high, in this patient, it's better to put the right atrial pressure in the formula and measure the FFR, taking in consideration the right atrial pressure, especially if you have a borderline FFR. So it may impact or may change the treatment strategy in this patients. There is some special situations like bifurcation stenosis. For example, if you have left main moderate lesion and you need to evaluate whether this left main is significant or not. If the patient has severe LAD stenosis, most of the flow is directed toward the circumflex, which called a coronary branch steal phenomenon. Here, if you look at this curve, if the child diameter stenosis, which is LAD stenosis, increased more than 70, it becomes really significant. So the coronary flow reserve, or the flow increase in the circumflex, which may underestimate the significance of left main. So if you have a proximal LAD severe stenosis, putting a coronary wire or pressure wire in the circumflex to estimate the severity of left main is doubtful. It may underestimate the severity of left main. If you have serial lesions, for example, if you have 2 or 3 lesions in the LAD and you are measuring IFR, if you put, for example, the IFR here to assess the significance of the proximal stenosis or stenosis A, the presence of this stenosis will increase the pressure in this compartment. So increasing the pressure here will underestimate the significance of this proximal. So how can we assess the severity or use FFR in such a situation? You put the IFR wire distally to assess the summation, whether actually the whole LAD, the sum of all these lesions, whether it's functionally significant or not. If it's not significant, so both lesions are not significant. If the IFR distally is significant, so you withdraw the IFR to not to see a value, but you see whether there is a step up in the pressure or not. Actually, IFR may help better than FFR, because if you are using FFR, you should use an adenosine infusion and see whether the step up, where the step up in the pressure, here or here. But using FFR to assess the significance of this lesion by putting just the pressure sensory wire here will underestimate the significance of the proximal lesion. What about myocardial bridge? Shall we use IFR, for example, or FFR to assess the significance of myocardial bridge or not? If you put the pressure wire within the myocardial bridge, you will find an overshouting. Actually, there is shouting of the systolic pressure. And here you find a diastolic gradient. That's why it's important, if you want to assess the functional significance of myocardial bridge, there is some actually case reports. No studies, no large studies that assess the functional significance of myocardial bridge using FFR. And the impact of this FFR measurement on the decision-making or the treatment strategy has not actually been evaluated in studies. But if you want to do this, you can use it by FFR and not using adenosine, but you can use a dobutamine challenge. So you can give inotropes to increase the contractility and to see whether it's significant or not by measuring the diastolic FFR, either the diastolic FFR or you can actually, not depending on the reading of FFR on the screen, but you get بتاخد الdiastolic pressure الديستال at the peak of dobutamine infusion, بتاخد الديستال diastolic والaortic diastolic, and then you divide both to get the diastolic FFR. It's not actually well validated, and as I said, the impact of actually value, حتى الvalue is not standardized, whether you'll use the same value 0.8 or not. So I think the use of IFR or FFR for functional assessment of myocardial bridge is really doubtful. What about the presence of collaterals? This is really very important. If you have, for example, a totally occluded or subtotally occluded RCA, and the LAD or the left systems gives retrograde collateral to RCA. If there is a lesion here, for example, in the LAD, shall we use an FFR or IFR in this LAD to assess whether it's significant or not? Here, the LAD does not supply only the LAD territory. It supplies also some of the RCA territory. So the mass of viable myocardium supplied by this artery increased. And we know that the maximal blood flow in a given coronary artery is proportional to the mass of viable myocardium supplied by this artery. So now, if you used the IFR or FFR to measure or to assess the significance of this LAD, it could be overestimated. You may find that the LAD is really significant, but after fixing the RCA, you will find actually the LAD is not significant. So if you are going to do IFR or FFR in an artery that's supplying or gives retrograde collaterals to another artery, you should open actually the first vessel first to ensure that there is an antegrade flow in this territory, and then you assess the functional significance in the donor artery here, like the LAD. But actually, in this case, for example, the FFR, when measured in the beginning, it was really significant, 0.75. However, after fixing the RCA, opening the RCA, the IFR, the value of FFR was 0.84, so mean that the LAD lesion is not significant. So at the end, what are the take-home messages? Important functional assessment of coronary artery stenosis, it should be performed accurately in order to be used to guide your treatment strategy. And when it performed accurately, it's really very powerful tool to guide the revascularization strategy, either for assessment of a doubtful lesion or intermediate lesion, or in patients with multi-vessel disease. And you should be aware of the physiological basis and assumptions, the artifacts, the limitations that can happen or you can face while measuring FFR, because you will use this tool to guide treatment. So you should be aware of all these artifacts, the physiology, the limitations that actually you can face while measuring FFR. And now still, as I said, there is a certain group of patients that we are using now FFR or IFR in this patient, but still we need studies to fully validate the use of functional assessment or FFR or IFR in patients with left main or patients with LV systolic dysfunction, because these patients were excluded, as I said, from the original large study, the FAME study that actually put a functional assessment now in class 1 in all the guidelines. Thank you, and I hope that you learned some tricks or get some points in measuring the FFR, and waiting for your questions.